that, please. Your attention here.
Great. Hey guys, I'm Annabelle. This is Viki, like Tom had explained. We just wanted to tell you guys a little bit about what we've been doing for the last couple of weeks. We're really excited to be here, and we've had a fantastic experience.
Perfect. Nice to meet you guys. So basically we did our shadowing experience at Northern Light Inland Hospital. It's in Waterville, Maine. It's right next to Maine General. And it's a very small hospital, but they have a great staff, great team. And then we shadowed in the surgery department, but we did, Annabelle did some outpatient. I did a couple days of outpatient, and then mostly we were in the OR, and then we also did some central sterilization. We witnessed how everything was processed, and it was just really cool to see because that was just a department that we really never heard about, but they are the heart and backbone of the hospital. And then so we were in the surgery room, and then each day, so that's how Inland works. So in the surgery department, each day, a different type of surgery takes place. So for Monday, it's usually urology. Tuesday and Thursday is general. Wednesday is OBGYN, and then Friday is orthopedics. And then so Annabelle will tell you about the surgeons that we follow.
Yeah, so this is pretty much the basis of our network that we were working with at the hospital. These were all fantastic doctors. They were really, great with pausing the operation for a second and just explaining, this is this muscle and this is this muscle and this is what we're trying to accomplish. Here's what you can learn from it. And obviously, Viki and I don't have much medical experience yet, so they really had a lot of patience for us and were very considerate about, what we were experiencing for the first time. It's not really easy going into an OR and seeing, baby being taken out of the mother's abdomen and blood everywhere, and it's really kind of shocking the first time, but they were so great about it, and they were really supportive and fantastic people. So to introduce a couple, Dr. Gibbs in general surgery, he was there usually, Tuesdays and Thursdays. He was like this big Scottish, or I think he was British.
Yeah, he was
and
British.
He had a great personality. He would just go into all of these anecdotes. It was really funny. Jeff Gagnon was the PA, and he was the only PA that they had in that department. But for me, it was really interesting because I was very interested in the PA profession. I'll get a little bit into that later. But he was there helping out the general surgeons. Dr. Schliehoff was also another general surgeon. Dr. Sampson was the orthopedic surgeon there on Friday. Dr. Heesers was a fantastic anesthesiologist. He did a lot of the procedures that we're going to explain here, having to do with spinal taps and labor epidurals, and he was really nice and guiding us around the hospital and showing us what he could. And then Dr. Richter was in the urological surgery, the urology department, and he did a lot with the kidneys and kidney stones and all of that. So really cool.
So basically, we're going to give you a couple of our of the procedures that we saw that we found interesting, might be relevant. A couple of these are actually very general procedures, but we don't know much about because you hear the name and then it goes past. So this first one is a lumbar puncture, and also known as a spinal tap. And so it's basically a procedure to remove cerebrospinal fluid, often for diagnostic purposes. And then so basically Dr. Hewers actually seeked us out and was just like, do you want to come see this? You might witness this in the future. And then it's definitely one of those things that you'll definitely see. So basically what they do is they go in with a needle and then with the lumbar region, and then they go in between two vertebrae, and then so they usually feel it out. You can use an ultrasound for guidance purposes, and it's easier with an ultrasound because you can see how far you're going with the needle, because sometimes you may go a little bit too far. But he's don't panic, just remove it a little bit, just just don't panic is basically the key. And then you just go in and then you measure the fluid pressure and then you remove the fluid however much you want. Usually it's in small amounts to send to labs or whatnot. In our case, the patient was actually feeling pain and then they got this done a decade ago and they said they felt better. So they came back and that's why they were doing the procedure.
Yep. Cool. So this was actually the first operation that I saw, which was really crazy. It was very overwhelming because there were a lot of people in the OR at that time, and the mother was actually awake for the whole procedure due to this labor epidural. And this labor epidural is very, very similar to a lumbar puncture or spinal tap. It's just, inserting a bit of anesthesia at a certain point in your spinal cord, and it numbs the entire region from that point down. So you're awake. And there's no, general anesthesia that you need to do, which general anesthesia comes with some complications because it could affect, the baby being born, and all sorts of other things. So that was really cool to see. They did that first off once we walked in. And then, after they cut all of the layers, they went right in. And they actually took out the uterus from the body, which was really crazy because it was huge. And we'd seen, or Viki had seen a hysterectomy, which was, removal of the uterus. And at that point, it was probably the size of your fist, but this one was probably this big. So it was cool to see how much that had expanded and, how your body changes to compensate for the things that are happening. And we got to touch a few things, which was really cool. We weren't supposed to touch the patient, but that doesn't mean you can't touch parts that were in the patient. So, so they're like, all right, strap on your gloves. And they handed us like an umbilical cord. And that was really cool because there are a lot of complications that come with umbilical cords. There's something called a nuchal cord, or a nuchal situation where it actually wraps around the neck of the baby, and it can be really dangerous and cut off, the, oxygen or whatever. The baby can become cyanotic, and it's very frightening. So you just have to quickly undo that. That was actually the first one that we saw. The baby came out, and there was a nuchal cord, and the nurses and doctors just went right in and removed it, which was great. And there's also a prolapse where, the umbilical cord is the lifeline of the baby. So if it's got pressure on it of any kind, it cuts off the blood supply and can actually be very detrimental and horrible. So that's a prolapse. But anyways, it's just a very vital thing. And it's got 2 arteries and 1 vein, and they were showing us, they were picking out the parts that we could see. Anyways, it was really cool. The other thing that we got to kind of touch and play with was the placentas. After you deliver the baby, you're supposed to deliver the placenta also. And this can look very different depending on the health of the mother. We saw one placenta that wasn't so healthy. The mother had been kind of on and off smoking while she was pregnant. And I can show you here. This one kind of is more of a smoker's placenta, and this one is what it should usually be. So the doctors also really tried to make it special for the parents. The father or the partner was allowed in the room, and he or she was dressed in full scrubs, and they were really excited. They would stay by the head of the mother. But, the nurses went around and took pictures of the baby, and it was really cool. Some good teamwork. And then obviously the process of sewing up was a lot more than I'd expected. They, went in and they were very careful to sew up each layer that they had broken open so that it would heal exactly as they went into, which I didn't know. So.
And then this was actually one of my most memorable one because it was my first procedure. I was in there alone because Annabelle was an outpatient. I was so nervous, and then I just like stood there and I was looking at it. I was like, oh wow, what is going on? Why are they using laser? Okay, cool. It was like so like in it was such a short procedure. It was only like around 45 minutes. And then he was like trying to explain. I think it was actually Dr. Richter who was there. And then he was like, oh yeah, just look at this. I'm just going to turn on the laser now. And you can just see like, I'm just cutting away the tissues. Don't worry, it doesn't even hurt and whatnot. And then so basically, I looked into this afterwards, and it's actually a more recent technology. And in the past, what they had to do was like a little bit more invasive, and the patient would not be able to go home. They would have to stay in the hospital for a little bit. But with this technology, they can remove it, and then they usually recommend this for patients with like recurring UTIs, bladder infections, when they have like bladder kidney damage, and then bladder stones, and then bleeding in the urine, blood in the urine. And then so they would recommend this because once you do this, it's like almost like immediate relief. Obviously, there's risks and stuff, but it's like lower compared to other procedures. And you don't even have to stay overnight. It's a short procedure. And then when he was doing this, he was like, if a surgeon doesn't make a surgery look easy, then he's doing it wrong. So from that, you can like really see, like, I was really impressed because I wasn't like scared or anything. I was just like, oh, that's all he's doing. And then he was like, he was fast, but he was careful. It wasn't like he was fast, he was rushing or anything like that. He knew exactly what he was doing. He's like, I go through this like hundreds, thousands, like per year. So he's like, even though this is so recent, but it's gotten so popular so that people, like patients are willing to accept it because surgeons are recommending it because it's like, it's good for them and it's easy and it gives like relief. So this was like one of my favorite actually.
And we saw a lot of these different technologies with the cholecystectomy, which is removal of the gallbladder. There's this technique called the laparoscopic technique, which is also very, well, it's relatively recent. I'm not sure exactly when it was, approved and came into practice. But basically, you see in the center picture here, you have all of these like very non-invasive ports that go into the abdomen, and through those you can fit in multiple tools, and you can see exactly what it is. It's almost like, honestly, it's almost like playing a video game where you have the screen, they turn all the lights off, and you're there with the controllers. Like, it looked very fun. It looked like they were having a great time. But basically, the procedure has to do with I'm sure you guys actually learned a lot about the gallbladder and the ducts that are attached to it, but it's peeling off the connective tissue where the gallbladder is attached to the liver, and then clipping the cystic duct here. And this can be very challenging because if you accidentally mistaken one of these common bile ducts, you can actually, cause liver damage, and all of that breakdown for cholesterol can build up and just cause an infarction and kill the liver tissue. It's a really bad thing. So they've got to be really conscientious, and it's hard to see too. There's a lot of tissues, and if you accidentally break some blood vessels, there's blood, and it's hard to distinguish what is what. So you have to be really well trained in your anatomy. So some complications that we witnessed is, once you go in there, you don't really know how big this inflamed gallbladder is. So these little ports, like it might be hard to take out the gallbladder from the little ports if it's really big. And actually, Viki was here during one of the operations where they were like, "Oh no, we have to do an open gallbladder." They were in the middle of a laparoscopic procedure, and they got in there and realized that the gallbladder was huge, and they couldn't remove it from just suctioning it out.
Yeah, and there was like too much adipose tissue, so basically he like went in, and then he was like, what is all this? And then he tried cutting it, and then he just couldn't remove it all, so he had to do an open surgery. It was almost like panic mode, but like calm calm panic. Like everyone was like, okay, we know what's going on. And they had to get all the equipment out because they were like, oh, we weren't prepared for this, but we can get prepared right now. And then they did it at the moment. And it was like, it didn't even take that long.
Yeah.
Just everyone was, yeah.
I mean, it's impressive, like, going into a surgery and expecting your procedure, but then all of these things might happen that you're not expecting, and it's your ability to make decisions and adapt to it that really makes a difference and makes you an adequate surgeon. Also, there's a level of professionalism that's going on with these surgeons making decisions and having focus, but there's also, this like social, side of it. We had some surgeons that were playing music and cracking jokes and talking about politics while they were, cutting into abdomens, which I don't know if that's like the safest thing, but they were just comfortable in that area, and you could tell that they'd done it so many times, and it was great. But so gallstones, there's a picture of gallstones here, and that's one of the main reasons why they take out the gallbladders, is they get stuck in the cystic duct, and every time bile squeezes into the liver, it clogs it and makes this painful feeling. And one time they were doing a cholecystectomy, and they were pulling it out, and the gallbladder starts leaking gallstones into the abdomen, which is really scary. So the Dr. Schlehoff was the one doing the operation, and she looked at the PA Jeff and was like, "Ready to go fishing?" So he takes out this little scooper and starts like scooping around for the gallbladders that had escaped, or the gallstones that had escaped in, and Jeff looks at me and he was like, "They look like banana-flavored nerds." So you could tell that they just love what they're doing, and they're so passionate, and they're just a great couple of people to, shadow.
And I think it was funny because when he said that, I was like, oh, they look like corn to me, because they were literally the size of corn when they got it out, and they were like showing us, and we're like, okay, that's cool.
Yeah, of course I was like, banana-flavored nerds, and
Yeah.
Viki was like, corn more like it. Anyways.
So this next one, it was a hernia repair. And so basically a hernia is just like a tissue bulge, and then what they usually do, so what Annabelle was saying earlier, so they can choose to have open surgery or they can do laparoscopic. So like in the past, like just 25 years ago, really the only way they knew how to deal with like hernia repairs was through like open tension repair. So they basically had to open the person up, and then they would just sew the healthy tissues back and then just call it good. But what happened with that is that it took a long time to recover and also left a scar. But in recent days, they're able to kind of push it back in and then use a mesh to protect it as aid for the abdominal wall. And then with that, the mesh stays in the abdomen, and also it actually promotes tissue growth over it. So it's a good support, and then it actually helps with it. But they can also do it laparoscopically, and they just make a couple of incisions, but they would also use mesh, actually, is really popular. So they would just put it through how Annabelle was saying earlier, and then they would just put it through, sew it back up, and then they're usually good to go. You don't even have to wait for that long. Obviously, you can't do anything strenuous for the time being, but it's actually very non-invasive, and the mesh is made of like flexible fiber, and it just like stays in the body, and it's actually a good protective layering.
So the second to last procedure that we want to talk about is this heel spur removal that we saw from Dr. Sampson, who is the orthopedic surgeon. And this was, orthopedic surgery was very different from any of the other surgeries that we saw, because it was very clean and it was 100% bloodless. So they would apply a tourniquet or some kind of pressure on the extremity, and it would cut off the circulation. And the reason for this was that it would lower the possibility of having a DVT, which is a deep vein thrombosis. And a deep vein thrombosis is basically a blood clot that can be dislodged and travel into, the heart or the brain and cause a big blockage, and it could, be really damaging. And so it was, it was really cool to see this one. We got to be up close. Basically, he just made an incision by the Achilles tendon, and he just started hammering away at that spur that you can see. Actually, I found a really good picture online. Google Images is the best.
It looks just like the one we saw.
It looks exactly like the one that we saw. So this is the calcaneus heel right here, and he just sawed this part off, and of course that part was attached to the Achilles tendon. So the Achilles tendon was then unattached, and he had to re-anchor that to the heel. And you can see he needed like a couple different tools for that, and I don't know, that was really interesting to see. But apparently these heel spurs come from a lot of different things, but mostly not stretching well, especially your calf muscle, because if your calf muscle becomes really tight, it pulls the Achilles tendon and pulls on the heel bone, and that can create some issues and heel spurs. So yeah, that was really cool.
And then, so this last one was actually the most gory one, and at that time I was really hungry. And then we went and saw this, and I was like, I'm a little less hungry now. But basically what happened was we were not there for the toe removal. I was like low-key. I was so happy, actually. But they came back. So what happened was the patient injured himself. He, stubbed his toe. He went into the ER. They just, did some suturing. But then he got an infection because he didn't take care of himself. That's what I'm quoting the doctors right now. But he got MRSA. So
infection and MRSA. Essentially, they told us, "Oh yeah, we removed the toe last week," and we're like, "Yeah, okay." Just some debridement. They revealed it, and there was half the foot was missing.
This is the toe, and
crazy.
Basically they made a pizza cut almost, and it was really close, and it was half gone, and then it's to protect the patient. But basically, what we saw was after he came in, and then he had to get debridement, basically just cutting away the affected tissues, the dead tissue, so that the new tissue can actually grow back. And then the most interesting part about this, actually, besides the toe and stuff, but it was we saw the wound vac technology. So basically they made the cut, and then they cut out, at the end, they cut out a piece of sponge that was the shape of the incision that they made. And they cut it, and then they put a film over it, and then they used a little vacuum device to suck, to make it in a closed space. And then we were like, oh, what does that do? And he was like, this actually increases circulation. And then after further research, it actually reduces swelling, and then it actually helps healing because it pulls in the edges closer together, which actually helps them. So that was really impressive. And I think that was one of the most impressive technology that I've seen. I was like, oh, wow, they thought about it this far, and this vacuum works in this way. And that was basically just a very short list of the procedures that we saw. So it was definitely an awesome experience. We saw departments, specialties, and we're just like, what?
Mm-hmm. Reflections. This is us. we seemed pretty cool back then.
Yeah.
Back 2 days ago. So we just wanted to talk about how much this experience meant to us. This is not a typical shadowing experience, being in the OR and sitting in the medical staff lounge with all of the doctors and seeing what kinds of things they talk about, and how they're thinking about the operation that they just did, or how they're preparing for it. So my plan going into college even was, I want to be a PA in surgery. That was the goal for me. I was going to do everything to make that happen. And of course, I'd never shadowed a PA, so there was a lot to learn on that part. So after this experience, I kind of got to see how the PA worked with the surgeons, and I was thinking maybe, I want to just go all the way and be the surgeon. And they seem like they have a lot more control over the operation that's happening. They have higher salaries. They are able to start their own private practice and specialize very particularly in something. Of course, it's a lot more school and everything like that, but suddenly like Dr. Fischer sounded pretty cool. But so I decided, if I'm really gonna make this decision, I might as well shadow the PA very very closely and make sure that that's like not what I want to do. So I shadowed him around for a whole day. I just followed him and saw everything that he did, talked to him about, his lifestyle and like what he loves about the job, what he would like to change if he were to go back, like 15 years from now and remake the decision of wanting to be a doctor or a PA, which would he decide? And he said, no, I would still choose to be a PA because there's a lot more control that you have as a doctor, but also there's responsibility and liability that comes with that control. You're responsible for that patient, and anything that happens to them is under your license. And that could become stressful in the environments that you're put in with other doctors and your decision making. Like there's a lot more weight to that, which is cool. It just depends on which kind of environment you're looking for. Also, you're on call, so that means that there's less time spending with your family and more time being at the hospital and supporting your patients. And I knew that for myself, what was going to help me make this the best decision in this case is what did I want my lifestyle to be like a couple years from now. And that's really hard because no one knows. Like I don't know what I will want for myself in a number of years. But I think that definitely I think that I'd want to be a PA because I'd want to spend time with family and have time for myself and have time to take care of my own hobbies and interests, as well as being in the medical field, and there's still a lot that you can do as a PA. So yeah.
I think for me, I wasn't even that far in the thought process. I think I was just like, oh, okay, let me test myself. Will I faint? I was dead set on I was going to faint. I was going to feel nauseous. I was going to feel sick. I stepped into the OR, and I was feeling sick just stepping in. But then when he started, I wasn't nervous at all. I didn't feel anything. Like, there was not one moment where I was like, oh, this is gross. I thought of it as, like, a learning tool. I was like, I got to see everything that I can right now before I, like, make the decision. Like, going in, I wasn't even sure if I want to go into the medical field. But coming out, I think I do. I think it's really cool. I don't know if I want to be a surgeon necessarily because I don't think I like that stuff enough to be, because they have to stand for all the time they're doing surgery, and I'm like leaning back and forth. Obviously, they cannot be like rocking or like adjusting themselves. They have to be really steady. So that's probably not for me, but I feel like I'm not scared, and I'm more sure that I can go into any field as long as I really want it.
Meanwhile, surgeon over here was like, oh, Mr. Heisers, I'm going to sit down. Yeah, but it's very different with everyone. And if you're feeling queasy or not, after a couple days of being in the OR even and seeing these procedures over and over again, you become accustomed to it. Doesn't matter if you have the gut for it originally or not, you adapt.
And Dr. Fischer said it's normal. It's very, very, very common for you to feel like blood, needles, or whatnot. But if you give yourself a couple of days, if you're just like willing to try it, you're probably going to get over it really fast. He said it's like one of the fastest things you really get over. You just exposure.
Mm-hmm. Exactly. So a couple of the projects that we did, while we were TAing for Tom over here, was setting up the lab. There's a ton of models that we're so fortunate to be able to learn from, and organizing those into each lab and each section that we were learning about was really important, and also the histology slides. I don't know if you guys really played around with the like microscopes and all of that, but basically we got there and they were kind of chaotic, all out of order, and you didn't really know what you were looking for or how you were going to find it. But we ended up going through the lab outline and organizing, putting all the slides into boxes for each lab and each body system that they went under, which was really cool.
And then one of the final projects that we're doing right now is the 3D modeling project. So we're trying to scan each of the models, and then, but right now we started kind of late, halfway through, but our goal really is to present a write-up, like finish a write-up, give instructions so that TAs in the following year can just follow it and just continue the project rather than having to explore, to experiment as much as we probably did. We went from like taking 60 pictures to 100 pictures per model at every angle, and even then the models wasn't as like we expected, so we're still testing with that, but it's actually going somewhere, so I'm pretty excited about that.
Yeah, I don't know if you guys are familiar with 3D modeling in general, but basically what we're trying to do is take the models that we have in lab and make them virtual and put them on the website so that you guys can click around it and look underneath it and really like flip it around on your home screen computer and study without having to come into the lab, which is really cool. So I did an internship blog site, and that's still not posted yet, but I'm working on it. I've written five or six blog posts, and I plan to do up to 7 or 8 by the end of this week. But basically, I just wanted to share day-to-day experiences and, reflections per procedure that I saw, and thinking about what does this mean? What is, how can we prevent this from happening in the future? Or, how does this affect, greater society? Problems like diabetes and cancer and, not having the healthcare to, really help and care for a simple stubbed toe. So, I don't know if you guys want to check that out. I'm going to be posting that pretty soon, and it'll be up for all of the next TAs to come in the future, and hopefully we'll just be building this journal, online journal of experiences. So thank you guys for being here. We want to thank Tom.
It was an honor.
for having us and, creating this experience for us and organizing everything, and, such a great Inspire and everything like that.
Yeah, I think my favorite part of this internship was that it wasn't just shadowing, it wasn't just interning. It wasn't just being a TA. It was like multifaceted, so that I didn't get bored or anything. I always had something to do, and I think that's just like one thing that I enjoy. So like I would highly recommend, if you're not like entirely sure of what you want to do, this would be something that you could devote a JanPlan 1 month.
Yep.
Yes, that was an amazing presentation. They covered all their bases pretty thoroughly there, but do you guys have any questions for them? This is a good opportunity to ask them things about their experience.
Did you guys like interact face? I mean, but did you interact face to face with patients, and was that like how did you?
Yeah. So there was the OR, and they were, usually under anesthesia by then. But we did spend a couple days in the pre-op with all of the nurses who were setting up IVs, Foley catheters, enemas, all sorts of stuff. And that was when they, would ask patient history. They would go in and, do you have a family history of diabetes, or, all sorts of other, what are your prior surgeries? And that's when we could kind of interact with them and be like, no, it's okay. Like, this will only hurt for a second, but it's going to be okay. But that was definitely special patient interaction, for sure. And their families were there too, so it's cool.
And then when they came out of surgery, like, they were brought to PACU, and then sometimes when they're setting up for the next procedure, we can come out, and then if they wake up, you can obviously, like, interact with them. A couple of patients did.
Mm-hmm.
Did you guys only see like the surgery and parts like that, or did you also see like the diagnosis process?
The diagnosis process? I don't think we actually got to see the diagnosis process, because once they were like, they made the appointment, it was like more or less, unless it was like unsure and they were doing like colonoscopies or like stuff like that.
That's a huge difference between, emergency medicine and something that's day surgery is they've already diagnosed everything and they schedule in advance the surgeries that they will have and the procedures that they will do. A lot of times it changes because they find things that they weren't expecting when they're in the surgery, but it is pre-diagnosed.
And then usually when like patients come in, they should already have like the instruments and whatnot like prepared for the patient, so that the patient shouldn't have to wait any longer once they get there.
If I may interject, so when I had the two of them apply in the fall, I asked them what kind of internships they were interested in, and they essentially said surgery. So when I was helping them to coordinate that with Inland, that's what I said. So Inland created sort of the experience for them. But in the past, I've had students who just exclusively worked in the wound care or the traumatic brain injury recovery, or I've had students, one student worked, so remember last night they were talking about the osteopaths, and they said that they had the one osteopath, student Stevens, who does nothing but OMT or whatever. 1 year, one of my students just shadowed her the whole time. I think the experience, the specific experience, whether it's clinical or surgical suite or whatever, is a little bit up to the students, and that changes year to year. So whatever what they're looking at is not what you're interested in. That's not, it's not what it has to be for you. Trisha?
Yeah. So you guys were there a lot, pretty much daily. Do you think you could like describe pretty much how they went? Like how early were you there? Were you just there for the procedure, or were you there to see like how they prepped everything?
So basically our day generally started at 8 o'clock, because that's usually when the first procedure was. But sometimes the schedule would come out the day before, and then we would look at the schedule, and then let's say there was a C-section. Usually it happened on Wednesdays, and then normally they try to schedule at 7:30. Occasionally it's like a noon C-section. But if we wanted to see that, we were welcome to come in. So basically we looked at the schedule, and then we're like, oh, we would like to see this and this and this and this. You're welcome to stay in the room while they prep. Basically they just set up everything, and like we really didn't want to get in the way while they set up. So we would go out and then like maybe talk to like outpatient or something like that. But you are welcome to stay with them and like just watch. I watched the first few setup because I wasn't sure what I was supposed to do, because there wasn't really like that much instruction. We had a lot of freedom. It was basically like up to us. And then we came in contact with a lot of like doctors, PAs, nurses. And then basically all the interactions, all the networking, everything that you wanted to do was like up to you. What did you want to see? What do you want to see? Yeah, we talked to a director.
Yeah.
And he like gave us.
Then again, you were free to ask any questions that came to mind while the surgery was occurring. You were dressed in full scrubs, hairnet, boot things. I don't know what there's called, boot caps, but basically hairnets for your boots. And you were fully able to, walk in and out of the OR while they were doing the surgery. So how much you wanted to see really depended on what you decided to be present for.
And how comfortable you were.
Exactly, yeah. It was neat.
Is there like a surgery you really wished you saw?
So I didn't quite catch what you said.
Is there a procedure that you really wish they were able to see that you didn't get to?
I think we didn't realize this until later on, like literally last week, but there's no cardio or neuro in like surgery for inland because they are a small hospital. I think they have it in other branches, just not this one. So that would have been really cool. Like I think neuro would have been really cool, but we didn't know that they didn't have it.
Yeah,
And
there was fusions of the like cervical vertebrae and all sorts of stuff, but there was nothing really directly related to the spinal cord itself, or the brain, or the heart. So getting that variety would have been pretty cool. Of course, it takes like a very intense level of specialization and department for that, but still would have been awesome. Any other questions?
Okay, thank you, Kira.